Intraocular Pathology Review, Part 4, Intraocular Tumors, Uveal Melanoma and Retinoblastoma. From the Department of Pathology at the Wills Eye Hospital, Sidney Kimmel Medical College at Thomas Jefferson University. Uveal malignant melanoma is the most common primary intraocular tumor in Europe and the United States. It's been estimated there's approximately 1,800 new cases yearly in the United States, or 6 cases per million. Major risk factors include race. Uveal melanoma occurs most often in blue-eyed patients of European ancestry. In the U.S., the incidence in white patients is about 8.5 times greater than that in African Americans, and the tumor is rare in Asia and Latin Americans. About 2/3 of uveal melanomas arise in Caucasians of European descent, who actually make up only 13% of the world's population. Han Chinese and Bengalis make up 24% of the world's population, but they only have 8% of the uveal melanomas. For that reason, retinoblastoma probably is the most common primary intraocular tumor. Predisposing factors include congenital ocular melanocytosis, or the nevus of Oda, and the BAP1 syndrome. The estimated risk of malignant transformation from nevi is relatively low. There's a slight increase in patients with neurofibromatosis. Congenital melanocytosis of the nevus of Oda. The tumor arises from a nevus of the uveal tract. Melanosis is 25 times more common in white patients with melanoma, and the risk for a white patient with melanocytosis to develop a melanoma is 1 in 400. The oncology service at Wills recently has shown that the risk for metastasis from a melanoma associated with nevus of Oda is more than 2 times greater. Clinical presentation. Melanoma may be an incidental finding on a routine examination, but the tumor typically presents with visual loss, generally due to a retinal detachment. Of course, you can lose vision from obstruction of the visual axis, secondary cataract formation, or rarely vitreous hemorrhage and cystoid macular edema. Pain does occur, but it typically occurs in the late stages of the disease, secondary to glaucoma. Some cases may have extensive extraocular extension, causing proptosis. And then there's rare cases with pseudo-inflammatory presentations secondary to tumor necrosis. Some cases may also present with a change in the color of the eye. Melanomas can arise any part of the uveal tract, iris, ciliary body, or choroid. They're most common in the choroid. They initially have a discoid or almond configuration. Then a certain percentage rupture through Bruch's membrane, assuming the classic collar button or mushroom configuration. This photomicrograph shows the ruptured in Bruch's membrane with the mushrooming head of the tumor extending into the subretinal space. Here's another example. The ruptured ends of Bruch's membrane act as a cinch or a purse string on the waist of the tumor. This leads to vascular dilatation in the mushrooming head of the tumor. Ciliary body melanomas tend to be diagnosed late because they are hidden by the iris and often have no retinal detachment, which is the most common cause of visual loss. They can cause unilateral cataract. Orange pigment frequently is found on the surfaces of melanomas. It can be seen on other actively growing lesions. You see a macrophoto of the orange pigment in the subretinal space. The orange pigment is either due to detached RPE cells with lipofuscin pigment, or composed of macrophages that have ingested lipofuscin and melanin. Question: is a small pigmented lesion a nevus or a melanoma? Carol Shields has done a lot of retrospective analysis of a very large series of uveal melanomas. She's had a bunch of mnemonics. The first was too fine small ocular melanoma, using helpful hints daily. T standing for thickness greater than 2 millimeters, F subretinal fluid, S for symptoms, O orange pigment, M for margins less than 3 millimeters from the disc, and UH for ultrasound hollow. Helpful hints, halo absence, D, drusen absent. Now these findings are based on ophthalmoscopy. She's recently modified the mnemonic based on multimodal imaging, and it's now TFSOM-DIM. Too fine small ocular melanoma, doing imaging. Doing imaging, diameter greater than 5 millimeters. Symptoms equal less than 20/50 vision. Subretinal fluid determined on OCT. Thickness based on ultrasound. Hollowness based on ultrasound. Transformation or growth into melanoma is defined as enlargement in basal diameter or thickness greater or equal to 5 millimeters. Most important combinations of these three factors including thickness greater than 2 millimeters, orange pigment, and diameter greater than 5 millimeters. Patients with a tumor thickness greater than 2 millimeters and orange pigment have a 68% Kaplan-Meier 5-year estimated risk for growth, and if it grows, it's probably a melanoma. Here are the 5-year estimates of nevus growth into melanomas. No risk factors, 1%. 5 risk factors, 50% 5-year estimate of growth. So these are risk factors for nevus transformation in the melanoma. Uveal melanoma, overall, there's a 50% mortality. The tumor tends to metastasize hematogenously to the liver. There's a propensity for hepatic metastases. Liver metastases occur in about 90% of the patients. This is an important paper from Cavella's group in Finland on tumor doubling time. The bottom line of this paper is that metastasis already has occurred before most tumors are diagnosed and treated. As a result, the ophthalmologist only achieves local control, and what he or she does probably has little or no effect on systemic spread and survival. And unfortunately, there currently is no effective treatment for metastatic uveal melanoma. There are a variety of prognostic factors for uveal melanoma. Some of these are evident on clinical examination. These form the basis for the AJCC Cancer Staging Manual. Important factors in that are size, ciliary body involvement, and extraocular extension. The Cancer Staging Manual includes this chart. You measure the basal diameter of the tumor, the largest basal diameter, and the height, and you can put the tumor in different size categories. Any melanoma greater than 18 millimeters in diameter, basal diameter, is a category 4. This chart shows the effect of increasing size on mortality. Large defined as greater than 15 millimeters. Now, ciliary body involvement is another factor. Ciliary body tumors have a poor prognosis, and it's uncertain whether this is due to delay in diagnosis or more likely intrinsic biological factors. Extraocular extension is another factor in the AJCC classification. This shows an example of the extensive anterior extraocular extension. Here's the corresponding photomicrograph. You can see the primary tumor in the ciliary body and choroidal stroma. There's tumor infiltrating the trabecular meshwork, and the canals in the limbal sclera with the tumor in the substantia propria of the conjunctiva. Additional prognostic factors are evident on routine histopathologic examination. These, of course, include the factors in the AJCC classification: size, location, presence of extraocular extension. But there's also additional factors such as cell type, calendar classification, presence of mitotic activity, presence of vasculogenic mimicry patterns, previously called vascular loops and networks, lymphocytic infiltration, and melanophagic infiltration. Cell type is called the calendar classification, named after George Russell Callender, originally a major at the AFIP in Washington when he did this initial study. He examined a series of uveal melanomas on file in the ophthalmic pathology branch at the AFIP and correlated the morphology with survival. We know that the appearance of uveal melanoma cells evolves as mutations accumulate and the cells become progressively less differentiated.
Uveal melanoma is a biological spectrum that ranges from bland spindle cells all the way up to markedly anaplastic epithelioid melanoma cells. Callender divided this biological spectrum into 4 categories that differ in prognosis. Callender's classifications included spindle A melanomas, spindle B melanomas, epithelioid melanomas, and melanomas composed of a mixture of spindle and epithelioid cells. Spindle cell tumors have a 25% 15-year mortality. Note, 15-year mortality. You can have late metastases in uveal melanoma. Mixed cell tumors have a 59% 15-year mortality, and epithelioid cells a 72% 15-year mortality. The Callender classification was subsequently modified as spindle A and spindle B were divided into spindle cell nevus, benign with 0% mortality, and spindle cell melanoma, along with epithelioid and mixed cell tumors. Dr. Ian McLean looked at this in a different way. He found that if epithelioid cells were present, 63% of patients died in 15 years. In contrast, if no epithelioid cells were present, the mortality at 15 years was 28%.
This shows a field of spindle A melanoma cells. Spindle cells grow as a syncytium with indistinct cytoplasmic margins. The spindle A nuclei have a chromatin stripe, a longitudinal chromatin stripe, which is thought to correspond to a fold in the nuclear membrane. Spindle B cells are less well differentiated. Again, the cells grow as a syncytium with indistinct cytoplasmic margins, but the nuclei are plumper and oval, and they have distinct nucleoli. At the other end of the spectrum, we have epithelioid melanoma cells. These are poorly cohesive cells. The cytoplasmic margins are distinctly seen. Again, they're poorly cohesive. They have round or oval nuclei, and they have large reddish-purple nucleoli, and the chromatin clumps along the inside of the nuclear membrane. This is called peripheral margination of chromatin. Mixed cell melanomas contain a mixture of spindle and epithelioid cells. Here's another case of a clonal mixed cell tumor. In the collaborative ocular melanoma study, 89% of the eyes that were enucleated with melanoma contained mixed cell melanomas. Occasionally you will see a melanoma that's totally necrotic. There was a category of necrotic melanoma in his study as well, but I think with careful microscopy you can determine the cell type of a necrotic tumor. This would be, of course, a mixed cell melanoma. Other prognostic features include what was initially termed vascular loops and networks, studied by Dr. Robert Folberg. Eventually these were called extracellular matrix patterns and eventually vasculogenic mimicry patterns. The presence of vascular loops and networks is associated with a poor prognosis. Lymphocytic infiltration. In lots of tumor, you see lymphocytes as a good sign. It means the immune system is fighting the tumor. Not so in uveal melanoma. Lymphocytic infiltration has a poor prognosis because tumor cells have to get out of the eye to stimulate the immune system. Paper from Finland also said there was a poor prognosis with presence of many macrophages and melanophages. There are additional prognostic factors that require special testing. These are quite powerful, actually. These include assessment for non-random chromosomal abnormalities and assessment of gene expression profiles. Val White and Professor Dr. Bornfeld from Germany did a lot of the original work on non-random chromosome abnormalities. One it's extensively associated with poor prognosis is monosomy of chromosome 3 in the tumor cells. If you have monosomy 3, 50% of the patients die within 3 years. Gains on chromosome 8 also play a role. This is Dr. Bill Harbour, one of our Wills ex-residents, who's now vice chair at Baskin Palmer and head of oncology. Bill did a lot of the original work on gene expression profiling. He found that uveal melanomas, the profile fell into two groups or two classes, class 1 and class 2, that differed markedly in prognosis. This is the heat map showing the two classes. This is a tie that I made for Bill showing the heat map. Initially, there were class 1 melanomas, low-grade tumors, low incidence of metastasis, gene expression profile resembling that of melanocytes. Then class 2 melanomas with a high risk for mets, greater than 90%. These were the case with epithelioid cells, vasculogenic mimicry patterns, and monosomy 3. There's been a slight modification of this. Now, class 1 has been divided into class 1A and class 1B. Class 1A are the real low-grade tumors, but in class 1B, there are late metastases, and this is due to mutations in the PRAME, or preferentially expressed antigen in melanoma gene. Class 2 remains the same. Tumors can actually be classified by the expression of 15 genes. Some of them are expressed up, some of them are expressed down. Problem is you can determine which tumors have the poor prognosis, but you really can't do anything about it since there's no good treatment for metastatic melanoma. This was the basis for this article in the New York Times a few years ago.
Gene expression profiling is performed as a fairly expensive proprietary test by a company called Castle Biosciences. Test is not done in Europe because it's expensive. The Ocular Oncology Service at Wills relies predominantly on chromosomal analysis performed at the University of Pennsylvania. Many ocular oncologists in the United States do order gene expression profiling.
I'm class 2. So why do you want to do gene expression profiling? Well, it said patients want to know to put their affairs in order. I think the most important thing is to select patients for clinical trials. You want to exclude class 1 patients with a good prognosis that could markedly distort the results of pharmacological studies. Genetic mutations in uveal melanoma. Uveal melanoma is different from skin melanomas. There are no mutations in BRAF. There are mutations in GNAQ or GNA11. These occur in about 50% of melanomas, and these appear to be an early event because they're also present in blue nevi and congenital ocular melanocytosis. BAP1. BAP1 is extremely important for metastasis. And as we noted before, PRAM is responsible for metastases in late metastases in class 1 cases. And that's preferentially expressed antigen in melanoma. BAP1 stands for it stands for breast cancer 1 early onset BRCA1 associated protein 1 gene. Inactivating mutations in BAP1 are found in 84% of class 2 melanomas. The BAP1 gene is located on chromosome 3, and inactivating mutations are thought to be disclosed by monosomy of chromosome 3. BAP1 syndrome is caused by germline mutations in the BAP1 gene. This syndrome includes uveal melanoma, mesothelioma, and some unusual skin tumors, and I think more tumors are being found in this syndrome as well. Martine Jager's group found that loss of HLA1 expression led to a better survival. This is Dr. Lorenz Zimmerman, who is the greatest American ophthalmic pathologist of the 20th century. He developed a hypothesis based on survival data and suggested that enucleation of uveal melanoma increased tumor deaths by disseminating tumor cells. Well, one of the things that the COM study showed that the hypothesis was not true. The metastasis already has occurred when the patient is treated. Treatment of posterior melanomas. Essentially, the great majority are now treated with plaque brachytherapy. Some larger tumors are still enucleated. Tumors that recur or have secondary complications are enucleated. In some areas, proton beam therapy or helium ion therapy is available and used. And then there are other treatments. The COMS study, the COM study, showed that survival after plaque and enucleation are similar. This is a malignant melanoma of the iris. Most iris tumors are melanocytic. They include freckles, which I think are small, non-progressive nevi, larger spindle cell nevi, the magnocellular form of nevus called a melanocytoma, which can occur in the iris, melanomas, different types of melanomas. We have discrete nodular tumors, diffuse melanomas, and tapioca melanomas. Now, most iris melanomas are low-grade spindle tumors, but there are some exceptions. This actually was a mixed cell melanoma of the iris. Most iris melanomas occur in the inferior sun-exposed part of the iris. The mean age of affected patients is about 10 years younger than patients with posterior segment tumors. Iris melanomas have a relatively favorable prognosis, about 4 to 10% mortality. In the past, the mortality of bona fide iris melanomas probably was underestimated due to the inclusion of a lot of nevi in the series. Actually, the prognosis of an iris melanoma actually may be similar to a posterior segment tumor of similar size and cell type. Again, we're dealing with small tumors, and most of them are low-grade spindle melanomas. We hardly ever see melanomas in the laboratory anymore because most pigmented lesions are observed and the great majority of them do not enlarge. Here's a case that we did receive in the laboratory. It's a low-grade spindle melanoma with a characteristic plaque of bland spindle cells on the anterior surface of the iris. Not all iris melanomas are low-grade, however. This tumor does contain epithelioid cells. It's a mixed cell melanoma. There's your epithelioid cell. Here's an interesting case we received a few years ago. This patient had a flat lesion, a very bland flat lesion that developed this pedunculated nodule. A local resection was performed. The flat portion of the tumor, shown at bottom left, is composed of very bland spindle cells with finely dispersed chromatin, no nucleoli. These are nevus cells.
In contrast, the cells in the pedunculated mushrooming head of the tumor are epithelioid cells. They have nucleoli and abundant cytoplasm. This is a mixed cell tumor.
Watch out for the patient who says that their eye has become darker and who've developed glaucoma over a year or two. These patients typically have a diffuse iris melanoma. They have acquired hyperchromic heterochromia iridis and secondary glaucoma. This scenario of diffuse iris melanoma typically is associated with higher grade tumors that contain epithelioid cells. This is a series of 25 cases of diffuse iris melanoma reported by Hakan Demirci from the Oncology Service. Again, in this series, retrospective review of 25 cases, chief complaint was my eye got darker in half. 80% of these had epithelioid cells, and misdiagnosis was common. 50% of the cases were initially diagnosed elsewhere as having glaucoma, and about one-third had prior laser or surgical treatment for glaucoma. 4 of the 7 cases with episcleral invasion had prior filtering surgery, and liver metastasis developed in 13% of cases, which is pretty high for iris melanoma. Other pigmented lesions of the fundus include nevi, the magnocellular nevus melanocytoma, congenital hypertrophy, the RPE, congenital group pigmentation or bear tracts, adenomas and adenocarcinomas of the retinal pigment epithelium, rare tumors, combined hamartoma, the RPE and retina, hyperplasia, the RPE. Okay, here is a choroidal nevus. Again, it does not have orange pigment. It does not have associated fluid. Drusen on the surface of a pigmented lesion suggests that it probably is a nevus. Melanocytomas classically are associated with the optic nerve, but as I said before, they can occur in the iris, ciliary body, and choroid. This is a magnocellular form of nevus. It can involve any part of the uveal tract. Again, they're benign tumors. I should be able to show you pathology, but this is a tumor that appeared to behave aggressively and was associated with severe pain. The patient demanded to have an enucleation, which was done. Here's the enucleated specimen. The heavily pigmented tumor is protruding 3 millimeters into the vitreous cavity. We can see the yellow spot of the macula lutea next door. Histopathology. One of the classic features of melanocytoma is that they are intensely pigmented and black in color. To evaluate the nuclei, which we have to do to classify the tumor, we have to treat the tumor with bleach, potassium permanganate, and we bleach out the sections. On the left is the unbleached tumor. On the right, we see the bleached tumor. A low nuclear cytoplasmic ratio. You can see a nucleoli in melanocytomas, however. This is an unusual case we seen many years ago. This was a patient who was followed for many years with the diagnosis of a melanocytoma, and when she passed away, the tumor actually turned out to be an adenoma of the retinal pigment epithelium. Congenital hypertrophy of the retinal pigment epithelium, chirpy. Before indirect ophthalmoscopy was invented, the eyes were enucleated for this. This is probably a low-grade neoplasm of the retinal pigment epithelium. There's not a lot of histopathology. Here's one case, large, tall RPE cells chock full of melanin with macromelanosomes. Sharpies typically develop areas of depigmentation called lacunae. Here's histopathology of lacuna, showing an area of chorioretinal adhesion where the retina is adherent to Bruch's membrane, where the RPE is absent. This is a ultraviolet microscopy photo showing the margin of a Sharpie. The normal RPE on the right is full of lipofuscin. The Sharpie on the left has no lipofuscin, suggesting that the RPE is non-functional. And as a result, there are no overlying photoreceptors, and there's typically an area of scotoma.
This old OCT shows absence of photoreceptors in the lesion and shadowing of the choroid by pigment.
Rarely, Sharpies can be observed to enlarge if you do enough photographs over time. Rarely, they can also give rise to solid tumors. There's a small series of solid tumors arising from Sharpie reported from Wills. One of the cases we were involved in is this tumor. It was actually a RPE carcinoma arising from Sharpie. Well, why isn't this a melanoma? Well, it's on the inner surface of Bruch's membrane. It's not involving the stroma of the choroid. At the base, we can see thickened RPE. This is the Sharpie that gave rise to the tumor. Unfortunately, the term Sharpie has been applied to the pigmented ocular fundus lesions and Gardner syndrome of familial colorectal polyposis. If you do a Google search for Sharpie, you'll find a lot of papers in the general medicine literature calling these lesions Sharpies. They tend to be multiple, they tend to be irregular and partially depigmented. They don't look like solitary Sharpies. This is a direct correlation of a patient that had Baer tracts or congenital group pigmentation, sort of the first cousin of Sharpies. This patient had a retinoblastoma, so that's why we were able to get the eye. You can see that the RPE cells at the bottom have increased amounts of melanin. Some of them have full thickness melanin pigment.
This is a microcystic adenoma of the retinal pigment epithelium. It's arising from the RPE and resting on the inner surface of Bruch's membrane. It does not involve the choroidal stroma. Hemangiomas are benign vascular tumors of the choroid. Although they are benign from a systemic standpoint, they need to be treated to save the eye. There typically is overlying cystoid retinal edema, and patients may develop exudative retinal detachments and neovascular glaucoma.
The sporadic hemangiomas tend to be discrete, localized orange tumors. The hemangiomas associated with Sturge-Weber tend to be diffuse and give rise to the so-called tomato ketchup fundus appearance. Here's a clinical photo of a discrete sporadic hemangioma. Histopathology of this hemangioma, the choroid, shows relatively little stroma. We just see tubules of endothelial cells comprising the vascular lesion. Uveal metastases probably are the most common intraocular malignancy. If everybody died from cancer, had their eyes examined, maybe 20,000, 30,000 cases would be identified. Most of these aren't seen by ophthalmologists. These tend to be multiple, numbular, and amelanotic. They tend to be present between the macula and the equator, where the blood supply is greatest. They frequently cause exudative retinal detachment with shifting fluid. In a most recent publication by Carol Shields, 37% were associated with primary breast carcinoma. The patients with breast carcinoma frequently have a prior history of treatment and are known to have that tumor. About a quarter of them have lung cancer, and the uveal metastasis can be the presenting manifestation of an occult primary tumor. Interestingly, about 1/3 of patients have no prior history of cancer. Here's an example of multiple METs in a patient with breast carcinoma. Again, posterior pole, amelanotic, coin-shaped, multiple, bilateral. 37% in women with breast CA, 26% in lung, which may be the presenting manifestation. Here's an example of a lung metastasis. This patient had no history of lung cancer, was a heavy smoker.
The diagnosis was confirmed by fine needle aspiration biopsy. Choroidal metastasis may be the presenting manifestation of an occult lung cancer.
Here's another example, sort of a diffuse infiltration of the choroid by lung cancer. In general, if a tumor is shaped like a mushroom, it's a melanoma. Now, occasionally you'll see rare mushroom-shaped metastases and mushroom-shaped schwannomas. Jerry Shields has a whole series of mushroom-shaped lesions, but I would say if it's a mushroom, you're probably about 99% certain that it's going to be a melanoma.
This shows histopathology of metastatic mucus-secreting carcinoma to the choroid. We see nests and islands of tumor cells. Special stains like colloidal iron and Alcyon blue are used to demonstrate the presence of mucin within the tumor cells. Autopsy studies suggest that metastatic carcinoma may be the most common intraocular malignancy. However, most cases are not seen by ophthalmologists. The nests and islands provide acoustic interfaces responsible for the solid appearance of metastatic carcinoma on B-scan ultrasonography. This acoustic solidity contrasts with uveal melanoma that tends to look hollow on B-scan ultrasonography. We actually see very few metastases in the laboratory. Some cases respond to chemotherapy, but the overall prognosis is poor. We now have immunohistochemical stains that allow us to determine the location of a primary tumor in a patient who is not known to have cancer and has an unknown primary. And the diagnosis of metastatic carcinoma needs to be confirmed.
Here's an eye with a total hemorrhagic retinal detachment and a choroidal mass. This patient had a remote history of breast carcinoma. Again, immunohistochemistry can identify the primary tumor. Here's the histopathology of that case. You can see that it is a appearance of the carcinoma, sort of a papillary tumor. It's immunoreactive for cytokeratin 7, which is a stain for cytokeratins seen in carcinomas. AE1, AE3, the pan-cytokeratin is positive, and breast 1 indicates that this is a breast carcinoma, and the tumor also expresses estrogen receptors. Ki67 proliferation marker was also positive. Other primary intraocular tumors include peripheral nerve sheath tumors, leiomyomas of the ciliary body, rare tumors of the iris, pigment epithelium, and ciliary epithelium, osteomas, astrocytomas, and medullopitheliomas. Peripheral nerve sheath tumors or choroidal schwannomas are quite rare. I think Jerry Shields has seen about 10,000 uveal melanomas, and he's probably seen less than 10 peripheral nerve sheath tumors. These are quite rare, and they're clinically indistinguishable from melanoma. They also stain positively with S100, melanoma stain with S100, so you need additional neural markers to confirm the diagnosis. Leiomyomas typically occur in younger women. They're often present in the suprauveal space, can be shelled out. They are pulsicellular spindle cell neoplasms with finely fibrillar eosinophilic cytoplasm, and they are immunoreactive for smooth muscle actin. This is a Fuchs adenoma or coronal adenoma, probably the smallest tumor in the body with somebody's name attached to it. This is a benign adenoma derived from the non-pigmented ciliary epithelium. It is a tumor of a single ciliary process. The tumors of the non-pigmented ciliary epithelium have important histopathologic features that will enable us to distinguish them from melanomas. The tumor rests on the inner surface of the ciliary body and typically does not involve the ciliary body stroma. There are bands and strands of epithelial cells on PAS-positive septa, and they're pools of hyaluronidase-sensitive acid mucopolysaccharide. Those are relatively common. Again, uveal melanomas are found within the stroma of the ciliary body. These tumors rest on the inner surface of the ciliary body. Rest on the inner surface of the ciliary body. Bands and strands of tumor cells on PAS-positive septa. Pools of hyaluronidase-sensitive mucopolysaccharide, all features of ciliary body tumors. Now, there's a very rare tumor of the ciliary body, a pleomorphic carcinoma. This has some very unusual features. It is potentially fatal, and it's typically found in an eye that has been blind for decades, a tisical eye that's been blind for decades. And there have been fatalities associated with extraocular extension. I've only ever seen 2 cases of this. Here's one. The tumor cells inside the eye are surrounded by PAS-positive septa. Osteomas, or osseous chorostomas of the choroid, tend to occur most often in young women, and they may be bilateral. They are yellow-orange tumors that have scalloped margins. They can decalcify and involute, and this may lead to choroidal neovascularization. There's a plaque of bone within the choroid. Again, as we noted before, osseous metaplasia, the retinal pigment epithelium, occurs on the inner surface of the choroid. These lesions, at least in the one case that's come to pathology, are present in the stroma of the choroid. This is a combined hamartoma of the RPE and retina. Question is, whether this is a neoplasm or not. Histopathologically, there tends to be a gliosis, glial proliferation, and strands of RPE cells responsible for the pigmentation. These are frequently present near the optic disc, typically seen in younger people, but they can be present out in the periphery as well.
Retinoblastoma is the most common primary tumor in childhood. There's only 250 to 300 cases yearly in the United States, but you certainly need to be quite familiar with this condition. And Eagle's rule number 1 is, if you want to get sued, misdiagnose cancer in a baby. Again, most common primary intraocular tumor of childhood, 1 in 15,000 to 20,000 births. The mean age at presentation is usually 18 months. Most cases develop by age 4, though there are rare cases that do develop in adults. It affects both sexes equally, and 1/3 of cases affect both eyes. And if it affects both eyes, that tells you that the patient has a germline mutation and can pass on the disease to offsprings. Some cases have a definite family history. The classic clinical presentation in the United States and Europe is leukocoria, or a white pupillary reflex. Blind eyes frequently have crossing defects, so strabismus is also seen. Rare presentations include pseudoinflammatory presentations like orbital cellulitis and pseudohypopion formation. Neovascular glaucoma occurs in the later stages of the disease, and in some parts of the world where diagnosis and treatment is delayed, patients typically present with orbital tumors and massive extraocular extension. There are rare cases of congenital retinoblastoma. It's leukocoria. This is also termed the amaurotic cat's eye reflex, white pupil. The abnormal pupillary reflex may be initially detected in family photographs. Again, we see the leukocoria in this child. Here's another family from Central America. The affected child is an albino. Note the difference in the pupillary reflexes. She has oculocutaneous albinism and retinoblastoma. This is the grandson of my technician. She was showing me photos on her computer. When I saw this one, I suggested that her grandson should have his eyes examined. He was examined by oncology and found to have a totally normal fundus. This is an example of physiological leukocoria. The optic nerve is actually responsible for the white pupillary reflex.
A retinoblastoma sort of has an encephaloid appearance, like a mini brain tumor. Of course, the retina is a peripheral colony of brain cells. The tumor can arise from the inner retinal layers and invade and seed the vitreous. These are called endophytic retinoblastomas. The tumor arises from the outer retinal layer. It's called an exophytic retinoblastoma. And this typically gives rise to retinal displacement, retinal detachment, and anterior displacement of the lens iris diaphragm. Here we can compare leukocoria from in the case of exophytic retinoblastoma and endophytic. You can see the retinal vessels in the detached retina in the exophytic tumor and the fluffy material in the vitreous in the endophytic tumor. The rarest growth pattern of retinoblastoma is the diffuse infiltrative retinoblastoma. This is least common, maybe 1.4% of cases in one series. Interestingly, this is seen in older children, mean age 6 years. So these cases frequently are misdiagnosed. People aren't thinking retinoblastoma in a 6-year-old. They frequently have pseudo-inflammatory signs. There's often a tumor in the anterior chamber forming a pseudohypopion. These cases are always unilateral. They're sporadic somatic retinoblastomas. Another feature that you typically see is the presence of tumor in the zonule. This is histopathology from a similar case, just showing this diffuse thickening of the retina by tumor. There's frequently not a focal tumefaction, and there is not calcification. This shows the example of the pseudohypopion. In another case, again, a hypopion in a quiet eye should suggest a possibility of this tumor. This is a child that was admitted to the Children's Hospital of Philadelphia with a admitting diagnosis of orbital cellulitis. This is an example. This actually is an example of aseptic orbital cellulitis. Here is the child's eye. We see a very large pseudohypopion of tumor cells. These cases that develops aseptic orbital cellulitis frequently have severe neovascular glaucoma, which causes infarction of intraocular structures in addition to the tumor, and that causes the inflammatory signs. Unfortunately, in some parts of the world, this is how retinoblastoma presents. This is a child from Tibet. We saw sections from this case histopathologically, and this indeed was a retinoblastoma. Retinoblastoma is composed of poorly differentiated neuroblastic cells. They have scant cytoplasm. There's lots of apoptosis and lots of mitotic activity. The scant cytoplasm causes the tumor to have a basophilic appearance. The tumor arises from and destroys the neurosensory retina. This endophytic retinoblastoma is arising from attached retina and invading the vitreous cavity. Retinoblastoma tends to undergo necrosis when the cells extend about 90 to 110 microns away from a nutrient vessel. The necrotic cells lose their basophilic DNA and become eosinophilic. Cuffs and sleeves of viable retinoblastoma cells separated by eosinophilic necrosis are a characteristic histopathologic feature of retinoblastoma. Another example, viable tumors with basophilic cuffs and sleeves. Necrotic tumor is eosinophilic. And dystrophic calcification frequently occurs within the area of necrosis. Calcification is a very characteristic feature in retinoblastoma and can be help you make the diagnosis because it can be seen in various imaging studies. Varying degrees of retinal differentiation occur in retinoblastoma. We can see two types of rosettes and photoreceptor differentiation or floret formation. Homer right rosettes represent neuroblastic differentiation. There's no lumen, a central tangle of neurofilaments. These are seen in other tumors like neuroblastoma. A few years ago, one of the residents came up with a mnemonic for this. Homer Simpson likes jelly donuts. Jelly donuts don't have a hole. Now, you do have holes or lumen in the classic retinoblastoma rosette, the Flexner-Winter-Steiner rosette, named after two people. Homer Wright rosettes were named after a single person, James Homer Wright. The lumen of a Flexner-Winter-Steiner rosette corresponds to the subretinal space. The cells bordering the lumen are joined near their apices by a series of intercellular connections analogous to the external limiting membrane. Florets represent photoreceptor differentiation. They're the highest degree of differentiation seen in retinal tumors. The term floret refers to the floral-like bouquet of outer segments that we see here projecting through that neoplastic external membrane, photoreceptor differentiation. The pink flowers are photoreceptor inner segments. I think sometimes you can see some outer segment material as well. Note that there is absence of mitotic activity and apoptosis. The nuclei of the cells look fairly bland. Here's another example of photoreceptor differentiation, floret formation, neoplastic rods and cones. You tend to find photoreceptor differentiation in a viable area of tumor that appears eosinophilic relative to retinoblastoma, which is basophilic. A tumor composed entirely of photoreceptor differentiation is considered to be a benign variant of the retinoblastoma gene called a retinoma or retinocytoma. It's composed entirely of florets, benign manifestation of the RB gene. This is a case that was seen a few years ago. Case was from Delaware. It was picked up on pre-school screening. See classic features of a retinocytoma, sort of a translucent fish flesh appearance to the tumor cytoplasm, cottage cheese calcification, and an annulus of RPE atrophy. This case was followed for several years, did not change, and then on the next visit came back looking like this. The tumor had undergone malignant transformation into a retinoblastoma. The eye was enucleated, and we were able to confirm that. The arrow points to the what we were looking at initially, which is composed entirely of photoreceptor differentiation, the retinocytoma, and of course then we see the new malignant transformation, a classic retinoblastoma with cups and sleeves and necrosis. Here's the photoreceptor differentiation at the base of the tumor. This was the first histopathologically confirmed case of malignant transformation of retinocytoma. Spontaneous regression occasionally is found in Tysical eyes. We see multiple foci of calcified tumor cells and a glial scar. This probably occurs in the eyes with severe neovascular glaucoma with extensive intraocular necrosis that's associated with aseptic orbital cellulitis. Vitreous seeds are an important cause of treatment failure in patients with retinoblastoma. Types of vitreous seeds include dust, spheres, and clouds. Dust is composed of scattered single viable cells alternating with macrophages. Spheres are solid or centrally necrotic balls of viable cells. These tend to be clinically aggressive because they shed viable cells. Clouds respond poorly to therapy because they're composed predominantly of necrotic material. Spheres are seen in these photos. The centrally necrotic spheres have a bullseye-like appearance grossly. These photos show a cloud of largely necrotic cells. The totally necrotic cells are seen in these photomicrographs. Some of the cells contain degenerated apoptotic nuclei. In recent years, Dr. Francis Mounier has popularized intravitreal chemotherapy. This is an effective treatment for vitreous seeds in many cases and doesn't predispose to extraocular extension if performed carefully. Retinoblastoma can infiltrate along the optic nerve into the brain or the orbit. The tumor cells can be dispersed through the subarachnoid fluid to the brain and spinal cord. You can also have hematogenous metastases to lung, bones, and brain. If you have an anterior tumor that invades the substantia propria of the conjunctiva, you can have lymphatic spread to preauricular and cervical nodes. Generally, if you're going to get metastatic retinoblastoma, it occurs within 2 years of treatment. Recurrence typically is due to retained tumor cells in the orbit or beyond the point of optic nerve transection. There are certain factors that are indicative of poor prognosis. Clinical factors include delay in diagnosis, prior intraocular surgery, and the use of external beam radiotherapy. Now, external beam radiotherapy can kill retinoblastomas, but unfortunately it stimulates the formation of secondary tumors in the 1/3 of patients that have germline mutations, and the secondary tumors typically are things like osteogenic sarcomas. Conventional risk factors for metastasis in retinoblastoma include extraocular extension and orbital invasion, massive choroidal invasion, optic nerve invasion, typically retrolaminar invasion or invasion to the surgical margin, and anterior segment involvement. The significance of the anterior segment involvement is somewhat unclear because it typically occurs in conjunction with other prognostic factors. The Children's Oncology Group did a study on histopathology and chemotherapy, which I was a part of a few years ago. In this study, histopathologic risk factors found in enucleated eyes with retinoblastoma that served as indications for adjuvant chemotherapy included massive posterior uveal invasion, which was defined as greater than 3 millimeters in diameter, retrolaminar optic nerve invasion, and any degree of concomitant choroidal and optic nerve involvement. I think that the last is not as an important indication as it once was. This shows massive optic nerve invasion. Melanoma doesn't invade the optic nerve very often, but retinoblastoma really likes to invade the optic nerve. We can see it's behind the lamina cribrosa. Here's the location of the lamina cribrosa, the sieve-like structure in the sclera. Essentially, if the tumor is behind the lamina, it's extraocular. Here's some data from an old study from New York. If there was no optic nerve invasion, there was an 8% mortality. Pre-laminar, 15%. Behind the laminar, it jumps up to 44%. And of course, this is an indication for chemotherapy in most institutions. It gets worse if it extends to the surgical margin. I haven't seen that many. This is a case of massive optic nerve invasion. We saw a few years ago. The nerve is probably twice the normal diameter. Again, a lot of the tumor in the nerve is necrotic. There was viable tumor at the surgical margin. We also see there's a massive uveal invasion in this case as well. What's massive uveal invasion? Well, it's a committee looked at this and defined it as tumor that's 3 millimeters or more in maximum diameter, in width or thickness. I think the Europeans like to talk about full thickness choroidal involvement as well. This case is shown here is actually very massive. This is one of the cases from Wills Eye Hospital that was in the Children's Oncology Group study. When the study initially started, a PO, pupil optic nerve segment, was submitted. This shows an obvious retinoblastoma. This is a mixed growth pattern. It's both endophytic and exophytic. There were no high-risk features found in the PO segment. There was no choroidal invasion and no optic nerve invasion. So this child did not receive chemotherapy because there was no high-risk features. Unfortunately, the patient developed distant metastases several months later. We went back, we pulled our wet tissue from storage and section and submitted the clots and did find a focus, 3 millimeter, greater than 3 millimeter focus of choroidal invasion. So based on this case from our department, the whole study was changed, and we are now submitting the entire eye. When we look at an eye with retinoblastoma, we submit the pupil optic nerve segments, but we also breadloaf the clot sections and submit them as well, along with a transverse section of optic nerve from the margin of resection. And here are the breadloafed clots. Again, extraocular extension, bad news. Another feature that's being emphasized recently is the presence of anaplasia. There's one study that's from Atlanta suggesting that patients who have anaplastic foci do poorly. So this is a quite anaplastic area in this tumor. Different types of retinoblastoma. There are familial cases. There are cases associated with the so-called 13q- syndrome, where there's a deletion, a part of the long arm of chromosome 13. These cases were important because they initially suggested that the retinoblastoma gene was present on the 13th chromosome. The great majority of retinoblastomas occur in patients who have no family history. They're sporadic cases. 3/4 of them occur due to somatic mutations. But 1/4 of the somatic cases are new germline mutations that can be transmitted to offspring and are new hereditary cases. The retinoblastoma gene is located on chromosome 13 at the Q14 band. It is the paradigmatic recessive oncogene. The product of the gene regulates the cell cycle. If you don't have RB protein, the E2F transcription factor is activated. Some viruses that produce tumors do so by making proteins that inactivate the RB1 protein. As we said before, most cases of retinoblastoma are sporadic and are caused by somatic mutations in the retinoblastoma gene. But 1/4 of these sporadic cases have germline mutations and represent new familial cases. The familial cases are heterozygous for the RB1 mutation, and a second hit or inactivation in a retinal cell causes the tumor. RB carriers also are at risk for second tumors. These include osteogenic sarcomas and tumors of the pineal gland, an association that's been termed trilateral retinoblastoma. Here's a cartoon. Everybody has 2 copies of the RB gene. They code for a double dose of the suppressor substance. And here's a familial case, heterozygous for the retinoblastoma gene. Well, 1 copy of the gene is enough to keep cancer of the crab under control. The problem is when you lose that 1 remaining functional copy, this leads to malignant transformation. The mutation rate has been estimated to be 10 to the -7th, or perhaps even higher than that. Familial retinoblastoma is bilateral. It's been estimated it takes 10 to the 8th mitoses to make a retina, which is 1 order of magnitude higher than the spontaneous mutation rate. If you're heterozygous, there's a very good chance you're going to develop a tumor. And there's also a good possibility you will develop a tumor in both eyes. 2/3 of patients with germline mutations will develop bilateral tumors, and they can develop multiple tumors in the same eye. Sporadic somatic cases of retinoblastoma tend to develop in older children at an average age of about 2 years. Tumors in germline cases tend to develop early, on average about 1 year. If you see a retinoblastoma in a very young patient, like 3 or 6 months, there's a pretty good chance that that child may have a germline mutation or a rare RB1++ retinoblastoma. Cases with germline mutations may present with unilateral tumors, but they are at risk for developing a second tumor in the fellow eye. Here's a cartoon of a sporadic somatic retinoblastoma. We have 2 successive hits or gene inactivations in a single retinal cell. It takes longer for this to occur, presumably. The mean age is 24 months, and these are typically unilateral and unifocal. This conforms with Knudsen's 2-hit hypothesis. Familial cases are heterozygous and already have 1 inactivated gene. Only a single additional hit or gene inactivation is necessary. This presumably takes less time. The average age is 12 months, and 2/3 will develop bilateral tumors. Retinoblastoma carriers are heterozygous. The gene is actually recessive at the molecular level. If you make a Punnett square and mate a normal individual with a heterozygote, you'll end up with 50% normals and 50% heterozygotes. That mimics autosomal dominant transmission. The germline carriers are at risk for secondary tumors. It's estimated there's a 20 to 50% chance of developing a secondary tumor in 20 years. The most common is osteogenic sarcoma. You can have other soft tissue sarcomas. Interestingly, the incidence of osteogenic sarcoma has increased 500-fold outside the field of radiation. There's also an interesting entity called trilateral retinoblastoma. The term trilateral retinoblastoma refers to a retinoblastoma-like tumor of the pineal gland called a pineoblastoma that develops in a patient with a germline mutation who also has bilateral retinoblastomas. Here's an example. One of the secondary tumors, an osteogenic sarcoma that occurred in the field of external beam radiotherapy. External beam radiotherapy is avoided in the treatment of retinoblastoma. There were cases where it cured the tumor, and then the patient then developed the sarcoma when they're in their late teens or college age. We currently have a case at Wills where the woman developed a osteogenic sarcoma in one orbit, then a few years later developed a liposarcoma in the fellow orbit. If you see bilateral retinoblastoma, that tells you the patient does have a germline mutation. Now, unilateral involvement does not exclude heritable disease because only 60% of familial cases actually have bilateral tumors. It is accepted dogma that loss or disruption of both alleles of the RB1 gene is responsible for initiating all cases of retinoblastoma. These typical retinoblastomas are designated RB1-. However, an RB1 mutation cannot be found in approximately 2% of patients who have unilateral tumors and a negative family history for retinoblastoma. The tumors in these patients are designated as RB1++. Rushlow and co-workers examined more than 1,000 unilateral retinoblastomas and found that 2.7% were RB1++ tumors. The RB1++ tumors have unusual features. They are poorly differentiated, they behave aggressively, and they're diagnosed at a very early age. 4.5 months compared to 24 months for typical unilateral non-familial RB-negative tumors. The RB++ tumors are always unilateral and sporadic, and siblings are not at risk for developing tumors. The cytology of the tumors is also unusual. They're composed of undifferentiated cells that have large, prominent, round or oval nuclei with multiple nucleoli. Apoptosis is common, there's little calcification, and no Flexner-Wintersteiner rosettes typically are found despite the young age of the patient. Numerous rosettes typically are found in retinoblastomas enucleated from young patients. An RB-, and an RB++ tumor are compared in these two photomicrographs. Note the large oval nuclei with prominent nucleoli in the RB++ tumor. Many RB++ tumors have been shown to have amplification of the MYNC oncogene, shown here in this fish preparation. MYC may be the driving force for this type of tumor. These photomicrographs compare an RB-, and an RB++ tumor stained with an immunohistochemical stain for RB1 protein. The nuclei of the RB++ tumor are immunoreactive for RB1 protein, compared to the nuclei of the typical negative tumor, which don't stain. Normal cells in the adjacent retina serve as a positive internal control. In recent years, Dr. Jesse Berry from Los Angeles has reported on the use of DNA in aqueous humor as a surrogate tumor biopsy for retinoblastoma. Dr. Berry obtained aqueous humor from 3 cases of retinoblastoma and analyzed it to see if it contained sufficient DNA to perform genetic analysis. Cell-free DNA was isolated from the aqueous humor. The study demonstrates that tumor-specific DNA is present in the aqueous humor and can be safely biopsied and evaluated. This figure from her paper shows that the DNA from the aqueous and the tumor correlate well. The results suggest that aqueous humor can serve as a surrogate tumor biopsy when RB tumor tissue is not available. This will allow for analysis of tumor-derived DNA in RB eyes undergoing salvage therapy that have not been enucleated. In the future, it may allow clinicians to diagnose retinoblastoma in situations when the diagnosis is unclear. It also may help to determine whether certain chromosomal abnormalities or mutations in the RB1 gene correlate with prognosis or a response to therapy. A subsequent study showed that gain of chromosome 6p detected in DNA in the aqueous humor was associated with a 10-fold increased odds of enucleation. The differential diagnosis of retinoblastoma includes a variety of conditions that can be confused clinically with retinoblastoma. These are simulated lesions or so-called pseudogliomas. They include toxocariasis, nematode endophthalmitis, persistent fetal vasculature, previously called persistence and hyperplasia of the primary vitreous, Coats disease, and a variety of other conditions. Ocular toxocariasis, I haven't seen a case of this in 40 years. Classically, it was a unilateral condition seen in somewhat older children who had contact with puppies. There were different growth patterns, subfoveal granuloma, peripheral abscess, or diffuse endophthalmitis. Tended to see an abscess with lots of eosinophils. If you saw this, you would have to serial section the eye to find a fragment of the worm. Now, the ELISA test for toxocara antigen is only helpful if it is negative, because in some populations there are a lot of positive ELISA tests for toxocariasis. This is a clinical photo of one of the subfoveal granulomas. This is an old case from our files at Wills. I was able to find it shows an eosinophilic abscess with a fragment of worm. They actually had to do 60 serial sections to find this one fragment of worm. There's some evidence that the worm may be able to shed its cuticle and then migrate out that area. This is a gross photo showing the orbital contents and eyes of a 20-week-old fetus. The eyelids, of course, are still fused at this stage. We see the hyaloid artery and the tunica vasculosa lenis nourishing the developing lens, which is very round and spherical. There's also a Bergmeister's papilla. Abnormalities and resorptions of this fetal vasculature can give rise to persistent fetal vasculature, PHPV. Things to remember about PHPV or PFV is it's congenital, it's present at birth, and it's unilateral. Classically, the eye is microphthalmic. There's a retrolental plaque of fibrovascular tissue and a patent hyaloid vessel. And the ciliary processes typically are drawn centrally to their attachments to the margin of the retrolental plaque. There are often iris shunt vessels and other persistent fetal vessels. The lens can actually contain adipose tissue or rarely bone. Morton Goldberg suggested the term PFV in his Jackson Memorial Lecture. This is a classic case from Jerry Shields' file. We see the ciliary processes attached to the plaque behind the lens. There's also some very nice shunt vessels on the surface of the iris. Top right shows markedly drawn and stretched ciliary processes to the remnants of a lens that undergone spontaneous resorption. Histopathology shows the inwardly drawn ciliary processes below. Coats disease is the condition that probably will make it to the pathology laboratory most often, though we don't see many cases of this either. Typically it's unilateral and non-familial. The peak incidence is toward the end of the first decade. We have congenital vascular anomalies in the retina, including dilated telangiectatic vessels, microaneurysms, light bulb venous dilatations. We do see areas of capillary non-perfusion. There's massive exudation. In the bad cases, there's exudative retinal detachment, high bullous retinal detachments with retinal fluid rich in cholesterol clefts and lipid-laden histiocytes. If you see what looks like bilateral Coats disease, this can occur in patients with fascioscapular humeral muscular dystrophy. In this montage, we see the pupillary appearance. Coats disease can actually cause a yellow pupillary reflex or xanthochoria. Here's an example of a high bullous retinal detachment with secondary angle closure and large quantities of lipid in the subretinal fluid, cholesterol clefts, and foamy histiocytes. Histopathologically, we see the abnormal vessels in the retina and massive thickening of the retina by exudate. Here's a clinical photo showing the abnormal vessels. The corresponding fluorescein angiogram shows marked areas of capillary non-perfusion. Again, it's a bad sign when the retina is up against the back of the lens. Here again, we see abnormal vessels in the retina and thickening of the retina by exudates in its outer layers. This case also has florid neovascularization of the iris. This was an interesting case that was seen at Wills a few years ago. This patient actually presented with the cholesterol-rich subretinal fluid in the anterior chamber. There had been a retinal dialysis, and the subretinal fluid made its way into the anterior chamber. Retinopathy of prematurity has some features that are similar to retinoblastoma. It tends to be bilateral. It occurs in infants and is not congenital. Of course, we know the story about premature infants and supplemental oxygen therapy. We see vitreoretinal neovascularization that occurs at the posterior margin of the peripheral avascular retina. Folding of the retina can give rise to the appearance of retrolental fibroplasia. There's frequently temporal dragging of the fovea and optic disc. Here's a postmortem eye of a relatively early case. The peripheral retina shown at right is non-vascularized, and we can see new vessels developing near the margin of the avascular portion. Here's a more advanced case in a postmortem eye. Neovascularization has produced an accordion-like folding of the peripheral temporal retina. The neovascularization and fibrosis has led to the development of this white mass. The condition initially was called retrolental fibroplasia when it was first identified after World War II, when premature infants were first treated with supplemental oxygen. Of course, this appearance certainly would raise concern about a possible retinoblastoma. Embryonal epithelioma is another primary intraocular tumor of childhood. Fuchs applied the term dictyoma to a single case of this tumor that had a net-like pattern of tumor cells. Medullary epithelioma is a rare tumor of the ciliary body. It tends to occur in older children, average age about 4, becomes symptomatic about 4, diagnosed at 5. There are frequently cystoid spaces that can help you make the diagnosis with imaging. There's also typically a neoplastic cyclitic membrane and persistence of the hyaloid vessels. There are both benign and malignant medullary epitheliomas, and they are also teratoid and non-teratoid examples, and we'll show you that. There are rare cases that have occurred in adults, and fatalities generally are associated with malignant cases with extraocular extension. Here's a classic histopathology. We can see the tumor on the inner surface of the ciliary body and peripheral choroid. The tumor extends behind the lens, forming this neoplastic cyclitic membrane. There are two components. We see the basophilic epithelial components. There are cystoid spaces, and this is a teratoid tumor, which actually contains foci of hyaline cartilage. The clinical photo at top left shows an interesting case that actually had cartilage that was visible clinically. Histopathology of another case below shows a characteristic net-like dictyomatous pattern. In this instance, we see polarized bands of epithelium. These sort of resemble the embryonic medullary epithelium and are responsible for the name of the tumor. Again, this is sitting on the ciliary body. And we also see pools of neoplastic vitreous. These are pools of hyaluronic acid. The pools of hyaluronic acid stain with the colloidal iron stain for acid mucopolysaccharide, and the staining is abolished by pre-treatment with hyaluronidase, indicating that the material is hyaluronic acid. The teratoid medulloepitheliomas contain heteroplastic elements. And this is the case we saw before. We can see the cartilage in the gross specimen and in the histopathology. Heteroplastic elements, besides cartilage, include muscle, rhabdomyoblasts, and brain-like tissue. Recently, it's been shown that medulloepithelioma may be associated with the pleuropulmonary blastoma syndrome. Pleuropulmonary blastoma is a pediatric tumor of the lung, which may have cartilage in it. This is sort of interesting. This is caused by mutations in the DICER1 gene. The astrocytomas or astrocytic hamartomas in tuberous sclerosis complex presumably could be confused with retinoblastoma. The family history and seizure disorder can be helpful in diagnosis. This is a classic astrocytic hamartoma, the so-called mulberry nodule with the multiple calcospheroids demonstrated by the OCT. Again, these are typically non-progressive in most cases, but there is a subcategory of progressive giant cell astrocytomas that occurs in some patients with tuberous sclerosis complex. These tumors have, the cells have both glial and neuronal characteristics. And of course, these are progressive lesions and can be confused readily with retinoblastoma. Norrie disease. Norrie's disease is an X-linked recessive. There are bilateral masses of malformed detached retina, so-called pseudogliomas, and unfortunately the children are deaf as well as blind and frequently have mental retardation. Incontinentia pigmenti. This is an X-linked dominant condition. It's lethal in males. There's typically peripheral non-perfusion of the retina, leading to vitreoretinal neovascularization. These children develop vesiculobullous skin eruptions after birth. These are rich in eosinophils, and these heal, leading to a secondary marbleized pattern of skin pigmentation. They can have other CNS, dental, and ocular abnormalities. The gene is the NEMO IKK gamma gene, XQ28, which activates eosinophilic chemokine eotaxin. Here's a case that we saw at Wills a few years ago. Again, it was in a young girl who developed a retinal detachment secondary to this extensive vitreoretinal neovascularization. So, incontinentia pigmenti, the Bloch-Sulzberger type. If you see it in a boy, the boy has to have Klinefelter syndrome.